Good afternoon, everyone. Let me briefly tell you about my PhD thesis. I'm working on the perioperative management and critical care for patients with liver dysfunction. We chose this topic because of the complication and because of the severity of the situation that we are dealing with, and we have seen that there's a lot of room for improvement in the clinical approach. But before we go into the science and methodology, I'd like to briefly introduce myself. My name is Turan. I'm a doctor associated with the Department of Anesthesia and Intensive Therapy in Semmelweis. My mission statement is I aim to uncover the modalities proven by clinical data to be the most effective in the care for the critically ill. And as a young doctor practicing, I would like to see a widespread use of data-driven, feasible, and enhanced treatment protocols in clinical approach. So as you can see, I'm working on 3 projects, and all of these projects are concerned with different stages or different approaches to patients with liver dysfunction or liver failure. So why this topic is interesting? Because usually when the body is undergoing some kind of insult or injury, it's the liver that has to compensate the metabolic processes. But what happens when the liver is injured? So what happens actually is, if we remember the pathophysiology classes, it's a downward spiraling, so to say. So the impaired liver function is going to lead into a toxic buildup, which is going to create this toxic metabolic milieu, which is going to impair the function even more, cause a multi-organ deterioration, and this quickly spirals down into an acute liver failure. And you can see the reality of the situation when you consider that in the liver surgery settings, the complication rates can reach as high as 48%, and the mortality can be as high as 20%. And this is after decades of improvement in the safety of these surgeries. Now, in the ICU setting, the story is even worse. Recent studies have shown that around 61% of patients admitted to the ICU suffer from a so-called ICU-acquired liver injury. This is a poorly understood but extremely dangerous situation, which, if left unrecognized, can develop into an acute liver failure with almost 86% short-term mortality. Now, we chose 3 approaches to investigate based on the timing in all of these liver settings. So, pre-operatively, perioperatively, and in the ICU. And translational medicine is all about bringing science directly into clinical practice. Therefore, we paid extra attention that all of the modalities that we are investigating are feasible, they are affordable, they are easy to utilize in practice, they are easy to protocolize, and they are supported by reliable and contemporary data. So my first project is the effects of pre-operative steroid administration on intra and post-operative outcomes in liver surgery. So here we are looking at the pre-operative side of liver dysfunction. There is some clinical evidence that suggests administration of steroids before a liver surgery will significantly help reduce the post-operative complication rates. And this is due to its effect on the dysregulated immune response that comes as a consequence of liver injury. With this study, our aim is to analyze the data available from clinical trials in order to test the efficacy of steroids in reducing complication rates following liver surgery. As you can see our PICO here, we asked whether the administration of steroids actually reduces the post-operative complication rates. And our hypothesis is that they do. This is what we are going to be testing. Now, the implication is that this very widespread available intervention could enter into clinical practice and therefore lead to improvement in surgical outcomes in these very dangerous surgeries, or relatively dangerous surgeries. We have conducted our systematic search on 3 databases with the following search key: After the selection process, we ended up with 11 eligible randomized control trials, and we are right now on the stage of data extraction. My second project is comparing the effects of goal-directed fluid therapy versus conventional fluid therapy on the postoperative complications after major liver surgery. My friend Pani briefly told you about GDFT and how it works, but here there is evidence that suggests inadequate fluid management contributes to the postoperative complication rates. And GDFT has been proposed and recommended in international guidelines as a way to mitigate this risk. However, there is not enough evidence for specifically liver surgeries yet. Our aim is to assess the efficacy of GDFT in reducing complication rates after liver surgery, and this would be the first meta-analysis in this topic. We asked whether GDFT reduces complication rates or not, and we hypothesized that it does. And here you can see our PICO structure. We are interested in postoperative complication rate. The implication is that if we can implement goal-directed fluid therapy into liver surgeries, we might end up with reducing the complication rates, again, after these dangerous, relatively dangerous surgeries. We have conducted our systematic search on 5 databases, 24,773 results, but this is not duplicate removed, don't worry, it will get better. And my third project is the Icu Associated Project. This is the use of hemadsorption therapy for critically ill patients with ICU-acquired liver injury. Now, I'm very lucky because this topic was also briefly mentioned by my friend Chenge, so you have some background in it. ICU-acquired liver injury is poorly understood but extremely dangerous. It starts after the admission, and it can spiral down into acute liver failure. And hemadsorption therapy is a novel way of extracorporeal life support for these patients, which there is some evidence that suggests this is very efficient in reducing, let's say, the causation of this dysregulation or this injury process. This is going to be a systematic review, not a meta-analysis, because there is a lack of randomized control trials in this topic. With this systematic review, we aim to summarize and synthesize all currently available literature on hemadsorption therapy in ICU-acquired liver injury in order to formulate hypothesis-generating arguments for future clinical trials. We asked whether hemadsorption therapy is effective in reducing the levels of cytokines and liver dysfunction-related metabolites in critically ill patients with acquired liver injury, and whether it leads to better clinical outcomes. And based on the science behind it, we hypothesize that it does. And this is going to lead our systematic review now. And implications of our study would be to finally define primary endpoints for future clinical trials, which in turn could turn into improvement in clinical outcomes. Again, 5 databases, systematic search, 3,417 results. As you can see, these are the 3 studies that I have just mentioned, and hopefully we will be able to submit all of them by the next spring. And I would like to leave you with the quote that leads all of my professional life. It is the difference between screwing around and science is writing it down, from Mythbusters. Thank you so much for your attention. I'm eagerly waiting for your questions.
Can you go to your first project, PICO? I saw that the patient population is, for example, transplanted patients. In our center, it is the standard of care to give steroids. Let
me give you a context for this study. This is an additional intervention, not the prophylactic steroid. This is on top of the standard steroid administration. This is preoperatively a high dose of steroid administration. So this is double steroid, let's say.
And how can you compare an immune modulated patient with a liver resected patient's outcomes? Because it's a huge...
Yes, by subgroup analysis.
That's the keyword. Okay, thank you.